The next question is regarding exit procedure and anesthesia for fetal surgery. So this is a new trending surgery, and the anesthesia implications of it depend upon the materno-fetal physiological considerations and the blood placental barrier. So what all are the procedures that are done under exit? So the most common fetal interventions that are performed, those are namely laser ablation for twin-twin transfusion syndrome, meningomyelocele repair, fetoscopic endoluminal tracheal occlusion surgeries, and the question of interest, that is exit or ex utero intrapartum treatment. That is, the uterus is incised, the baby is delivered, surgery is done there and there itself. So that is ex utero intrapartum treatment. So these interventions are conducted closer to term of the pregnancy. What is done is, after hysterotomy, fetal oxygenation is maintained via placental circulation, which gives the surgical team time to perform the intervention needed to allow the fetus to transition to extrauterine life. Specific interventions required to allow transition to extrauterine life will depend upon the fetal pathology involved. So airway obstruction may require rigid bronchoscopy and intubation, or neck dissection and retrograde wire intubation as well. So these are certain specific airway maneuvers that may need to be done in this procedure. If there's a large lung tumor, we may require thoracotomy and pulmonary lobectomy as well. Fetus is then delivered at the end of the procedure. So we will go through how the exit procedure is carried. So the chronology of exit procedure: first, general anesthesia with secured airway of endotracheal intubation with thoracic epidural is given. Volatile anesthesia agents are used for the maintenance, and titration is done for optimal uterine relaxation. So we can use uterine relaxants as needed, namely nitroglycerin. Magnesium has to be avoided because it prolongs the duration of action. That is, neuromuscular blocking agents. The patient will become floppy on excess magnesium. Continuous fetal monitoring has to be done with respect to pulse oximetry and echocardiography. After this induction and favorable surgical conditions, the surgeon performs hysterotomy and partially delivers fetal arm, the head, and the chest. Now, after the fetus is delivered, the fetus airway is secured, but lungs are not ventilated until disconnection from placenta has taken place. In the fetus, peripheral IV access is obtained, and the main point or crux of the case is placental connection has to be maintained throughout the procedure. Now, sometimes if you are anticipating difficult airway, you might require specific interventions such as release of strap muscles, retrograde intubation, rigid bronchoscopy, or tracheostomy. If indicated, a surfactant has to be administered. Oxytocin has to be administered to the parturient. Volatile anesthesia has to be discontinued, and epidural, if placed, it has to be activated for pain management. After everything is done, reversal of neuromuscular blockade and extubation once the patient is fully awake. So basically, maintenance of fetal monitoring with placental connection maintained throughout, and surfactant and oxytocin administration, all these are the crux of exit procedure. So this is the ergonomics of the operation theater, starting from one where there is the main anesthetist or the maternal anesthesiologist and the assistant. 3 is the timekeeper of the procedure. Here are the surgeons, that is the obstetricians on both the sides. Here is the nursing staff at 6. At 7, where the baby is being delivered, pediatric anesthesiologist and the pediatric surgeon will stand. If required, pediatric ENT surgeon will stand. There will be a neonatology unit at this side. What all equipments are needed? At 1, there is anesthesia equipment for the mother. Surgical equipments are behind the surgeons here. Pediatric intubation equipments are here with the pediatric anesthesiologist A rigid bronchoscope is kept just in case you need to tackle a difficult airway. Tracheostomy instruments are also in place. Then monitoring of the baby and drugs needed for the baby are there here. Suction and cautery and endoscopic tower. So this gives you a glimpse of how many people are involved in doing a successful exit procedure and the ergonomics of all these people involved here. So the rate of drug transfer across the placenta depends on pharmacological factors, that is molecular weight, lipid solubility, protein binding, and concentration gradient. And what all placental factors are involved in the conduction of this case is that placental drug transporters, the pH of maternal and fetal blood, surface area involved, thickness, and uteroplacental blood flow. So among all the drugs that we are using in anesthesia practice, which all undergo rapid placental transfer and why, this table summarizes them. So volatile anesthesia agents, your thiopentone, propofol, benzodiazepines, all these undergo rapid placental transfer in view of high lipid solubility. Again, opioids like morphine, fentanyl, and remifentanil, they undergo rapid placental transfer. Remifentanil per se is important here because it is metabolized rapidly by non-specific esterases. Hence, it does not lead to residual neonatal sedation. And that is why it is being preferred over fentanyl and morphine, even in adult cases that we are doing now. Remifentanil is coming up in a big way because of its specific metabolism pathway. Coming to non-depolarizing muscle relaxants, namely atracurium, they do not undergo rapid placental transfer because of large size, high ionization, and poor lipid solubility. Succinylcholine again does not undergo rapid placental transfer. Neostigmine will undergo in view of small size, and this can transfer faster than glycopyrrolate, which is dangerous because it can cause fetal bradycardia. So often recommended to combine with atropine for neuromuscular reversal. So neostigmine will fast and cross faster than glycopyrrolate, and glycopyrrolate being a quaternary amine compound, it will not cross the placental barrier. Sugamadex again has got minimal placental transfer because of its large size and polarized molecule. Dexmedetomidine again has high lipid solubility and causes rapid placental transfer. Atropine causes rapid placental transfer because of it being a tertiary amine, unlike glycopyrrolate, which is a quaternary amine compound. And local anesthesia agents, they undergo rapid placental transfer because they are weak bases. And there's a phenomenon called ion trapping, where once they undergo transfer into an acidotic fetus, they get ionized after placental transfer, leading to ion trapping, and they get trapped inside the acidotic fetal environment. So how do you manage the uterine tone in all this? So uterine contractions can result in increased uterine vascular resistance, umbilical cord compression, fetal bradycardia, and premature labor. Intraoperatively, profound uterine relaxation can be accomplished through the judicious use of volatile anesthesia agents, magnesium sulfate infusion, nitroglycerin, and beta agonists. So again, uterine contractions can be triggered by the loss of uterine volume that occurs during hysterotomy. This is mitigated by continuous infusion of warmed crystalloids into the amniotic cavity, ensuring a warm environment for the fetus. So in exit procedures, uterotonics are administered after fetal delivery. You can see in this table transplacental transfer of remifentanil. You can give it IV to the parturient in the dose of 0.1 to 0.2 mics per kg per minute, and fentanyl 1 to 2 mics per kg per hour. Atropine, fentanyl, and other muscle relaxants can be given directly in their respective doses. Tocolytics, what are all different tocolytics that can be used clinically? Magnesium sulfate, NTG, calcium channel blockers like nifedipine, atosiban, which is an oxytocin antagonist, NSAIDs like endomethacin and terbutaline. All these are tocolytics. So Maxulf in the dose of 4 to 6 gram loading dose over 20 minutes, followed by 2 to 4 grams per hour of infusion can be given. Volatile anesthetics for better relaxation of the uterine muscles can be given in the up to the ranges of 2 to 3 mac. Nitroglycerin 50 to 100 mics IV bolus can be given, or 0.5 to 3 mics per kg per minute infusion can be given, or 1 mg sublingual spray can be given. Nifedipine 10 to 20 mg orally can be given every 6 to 8 hours. Atosiban 6.75 mg IV bolus followed by 24 cc per hour infusion for 3 hours can be given. Then indomethacin 50 to 100 mg per oral or per rectal can be given, and terbutaline 250 mics IM or IV 5 to 10 mics per minute IV can be given. After we have studied the dosing of tocolytics, when we come to uterotonics which maintain the tone of uterus, oxytocin 1 to 2 units IV bolus can be given, followed by an infusion of up to 30 units per hour. Carboprost can be given 250 mics IM every 15 minutes and maximum of 8 doses can be given. And methyl ergonovin 200 mics IM, it may be repeated after 2 hours. So fetal drug administration, if required, the drugs are administered to the fetus either indirectly by the anesthesiologist via the transplacental route or by the surgeon in IVIM or intracardiac route. In the transplacental passage of drugs to the fetus, the parturient might receive higher doses of drugs than the clinical anesthesia requirement. For example, fentanyl, remifentanil can be given here for maternal and fetal sedation and analgesia. Direct administration of drugs to the fetus, why it is important? Because the advantage of tailoring doses according to the fetal needs while circumventing drug exposure to the parturient itself. Again, what are the most common sites of fetal IV access? They include umbilical, hepatic, and peripheral veins. What are the limitations? Vasospasm of the umbilical vein cannulation, arrhythmias, and tamponade with intracardiac administration, leaving this approach largely for cardiac procedures. So intravascular routes are preferred for exit procedures. Shoulders and buttocks of the fetus, these are the sites of IM drug administration with drug volume limited to 0.2 to 0.5 ml. So in an unanesthetized fetus, this can trigger a stress response that can cause the shunting of blood away from the muscles and lead to unpredictable absorption. This route is usually used in minimally invasive or mid-gestation open procedures as well. So in situations of fetal instability, it may be necessary to pause the surgical procedure and perform fetal resuscitation. So we should know when do we have to start fetal resuscitation. One is fetal bradycardia, that is less than 100 beats per minute of fetal heart rate. So for adult, in adult terminology, bradycardia level is set at 60 beats per minute of heart rate, but fetal bradycardia is set at 100 beats per minute. Fetal oxygen saturation of less than 30 to 40%, decreased cardiac filling, and impaired ventricular function. All these are indications to start fetal resuscitation. The next question is regarding pain. One regarding a scoring system known as Q-SOFA, and the sub-question is WHO ladder of pain. So regarding Q-SOFA or quick SOFA, that is sequential assessment of failure of organs. All these parameters are used to check sepsis, which is a life-threatening organ dysfunction that develops as a result of an impaired host response to infection. So basically, life-threatening organ dysfunction because of impaired immunity is sepsis. And what is shock? It is a subset of sepsis that progresses with deep circulatory, cellular, and metabolic abnormalities with higher mortality risk. So patients with septic shock need vasopressors to achieve an average arterial pressure of 65 mmHg or more. And in the absence of hypovolemia, serum lactate levels exceed 2 millimoles per liter. And the in-hospital mortality rate of these patients is over 40%. That is why quick scoring is essential to quantify, triage these patients, and start early treatment and prevent hypovolemia, prevent rise in lactate levels to decrease this mortality rate. So quick SOFA is a bedside prompt method that may identify patients with suspected infection who are at a greater risk of poor outcome outside the intensive care unit. It determines sepsis-induced prognosis in adult patients with suspicious infections in non-hospital emergency or general hospital conditions. So the SOFA score identifies organ failure in 6 systems and assigns 0 to 4 points for each of the system. So it is very cumbersome to go through the entire SOFA score because it identifies organ failure in CNS, RS, CVS, the hepatic system, the kidneys functioning, and the GCS. So the SOFA score is a combination of identification of organ failure in 6 systems, and you may not have sufficient time to go through all the 6 systems, and hence the quick SOFA score has been utilized, which checks 3 criteria and assigns 1 point for each of the criteria. So the first and foremost is low blood pressure, with systolic blood pressure being less than 100 mmHg, high respiratory rate of more than 22 breaths per minute, and altered mentation with a Glasgow coma scale of less than 50. So all these 3 criteria with assigned 1 point comes under quick SOFA score. So you can see there are various calculators available on the internet. You have to enter the history of the patient. You have to see whether there is altered mentation, the respiratory rate, and the systolic blood pressure, and the scoring is given accordingly for sepsis in ICU. So this particular patient with a score of 2 has a 13% risk of bad outcome, and this is a prompt to consider that sepsis is likely in this patient. So systemic inflammatory response syndrome criteria, they are another subset of criteria which are basically superior to this quick SOFA scoring for the clinical diagnosis of sepsis. And quick SOFA is superior to SERPs for predicting in-hospital mortality. So it is basically has got good results when you are trying to predict in-hospital mortality.